lungs today, and we are going to start talking about the common ones and common signs, Okay, I'll get you when it's time, Brian. Sorry. Um, so let's get started. The first one we're going to talk about is asthma. And asthma, and I want you to write this down, is a chronic condition and it is an autoimmune disease. And most people who have asthma will develop it, and it will be something that they continue to have throughout their lifetime. Now, there are cases where we call childhood asthma, and maybe because the lungs weren't fully developed, maybe because of respiratory problems at birth, or maybe because of allergies that they outgrow, that the children may have asthma. And at a young age, and as they get older, their lungs are not as susceptible and they outgrow that. So there are times and cases that people have gone on and had real bad asthma attacks as a kid, and it just got better as they got older. But what happens when we have asthma and we have an asthma attack is we actually have a constriction of those bronchus, bronchioles, bronchi, and alveoli. So they begin to squeeze and inflame. And so if that happens, are we getting air? No. There are more than 3 million cases worldwide every year. And depending on the time of the year, it may or may be worse. It may or may not be worse, because allergy season tends to, and real rainy, wet seasons tend to aggravate people who have asthma. This picture here gives you a good example, and we're looking at a bronchiole. So this is off the bronchi, and now this is the part coming off smaller to the bronchiole. And here's a normal one. We can see that it's pink, it doesn't look inflamed, there's no excessive mucus. And then here, in this one, we see inflammation with the swelling and the redness, the excessive mucus. You see all of the constriction around all of the parts of the airway here. So this is bad condition, right? And then I was talking about allergens like pet dander or cigarettes, pollen. These can be triggers for people who are asthmatic. And when they are exposed to them, it can actually bring on or bring about an asthma attack. Usually this happens, and I did not realize how many words were misspelled in this. Usually that happens when the respiratory tract begins to excrete excessive amounts of mucus. And like I mentioned in our last lecture, that is its defense mechanism, right? So something gets into the lungs or something gets into our airway, our body does two things. It starts to cough, to expel, and it starts to produce mucus to help get rid of and expel whatever's there, right? So what ends up happening is a vicious cycle. And I'm going to explain that. And I like this picture. All right, so here we have a normal, healthy, we see bronchi to our little bronchioles, and then check it out. Now we're going all the way here to our alveoli, and they look nice and healthy. But if you was to take a really close-up look, on each end of your bronchioles and stuff, you'll have tiny little submucosal glands, and they secrete mucus, and it's a normal amount of mucus is enough to lubricate. Because I was talking to you about how we produce a quart of mucus a day, and that's a healthy person. And that mucus and mucus-like substances like surfactant and stuff are vital to us breathing without pain and having no complications with our breathing. But too much mucus is going to actually clog up and cause irritation to the tissue and the swelling, and to the tissue in the surrounding areas, causing swelling, causing inflammation. So this is where this cycle comes in. So when the body senses that, we cough. When we cough, we get more constriction. And when we get more constriction, more mucus flows. More mucus flows, more inflammation flows. More coughing goes, more constriction goes. It's a circle, and it just keeps going and going and going. How do we break that cycle? That's what's key to an asthma attack. And asthma attacks have to be broken, and usually we do that by relaxing the bronchi and the bronchioles and the alveoli. And we do this with something called a bronchodilator. And we know that something that dilates makes it bigger, right? And that's what we want, because as we see in this picture, this is constricted. Look, we want to dilate that and open it back up. We want to reduce the swelling so that our body breaks that cycle. And for the longest, one of the only asthma treatments that we had was albuterol. This is a medication you should be familiar with. And albuterol is supplied in an inhaler, and that's what this is we're looking at. And they can be changed in and out and replaced, and it's shaken up and then it's sprayed. And I posted a video on the proper way to use an asthma inhaler, because a lot of people don't. And I also posted about how to put on a spacer to an asthma inhaler. That's beneficial sometimes for children. But getting this medication into the lungs via an aerosol, a mist, like breathing it in, allows for immediate action in most cases. And albuterol can be a life-saving treatment for somebody who's having a severe asthma attack. Now, and like I said in the beginning, all we had was albuterol. But now, as we've modernized with medications, we actually have medications now that can act as a preventative to prevent asthmatic flare-ups and to prevent asthmatic attacks. And those common ones, I'm sure you've seen commercials for Ceravent, Flovent, Singular, and these are medications that somebody takes and on a daily basis, and then they hopefully have to use their inhaler or albuterol when they have an attack, and that's a lot less because of these kind of preventative medications. All right, one of the other things that are very common with asthma attacks is a steroid, because we know one of the properties of steroids is to reduce swelling. So it's very common. I know as a paramedic, that was kind of my little cocktail to go to. First thing I did was, we gave them a nib treatment, and we supplied them with oxygen and started an IV, got some steroids and some fluid into them. And those were the normal, treatments that we went about. Um, and usually just getting that oxygen, getting the bronchodilator in there, it made a big difference, quick, fast difference for most of my asthma cases that I made. And like I said, this picture is good to refer to because it shows what happens. Now, I know I keep pointing to this because this is bronchitis, but this is going to be what happens in the asthma attack is the constriction like this that you see, is the swelling, and is the mucus. But it's a sudden, quick, fast thing brought on. And there's usually not too many warning signs. Sometimes people might just start having coughing or itching throat or something like that, something like an allergy. But these also are good images to represent chronic bronchitis and emphysema. And that's what we're going to talk about because chronic bronchitis and chronic emphysema, those two are a pair, and they are grouped under something we call COPD, chronic obstructive pulmonary disease. And how do you get that? 95% of the time, smoking cigarettes. All right. And eventually, what ends up happening to people who have COPD is that the walls of the alveoli, even though we have 600 million, they begin to pop and burst and be unuseful. So that oxygen exchange is not occurring in a large percentage of the lungs, the more that the COPD continues. These are the symptoms that we talked about with asthma, and of course shortness of breath and wheezing and coughing. And that wheezing is why? Because their airways are tightened and constricted. A nebulizer, and I mentioned that, I posted this video, and hopefully everybody's watched it, but a nebulizer is when we place a mask and then we put a liquid medication and we use oxygen or air to flow the medication so that when the patient breathes it in, they're breathing it in directly into the lungs as they would naturally breathe. And this is an excellent way we deal with pediatric patients who are having asthma attacks, because it's really hard to get a 9-month-old to take a hit of this inhaler. That's not going to work. But we can put a mask on them. We can administer them the medication that they're needing, right? And then we were talking about COPD. I mentioned it. And this is it if you want to know how to spell it correctly. And this is the abbreviation that everybody uses: chronic obstructive pulmonary disease. And the name says it pretty much at all, because chronic, we know, means what? Long term. It means, do we have a cure for it? Do we have a fix for it? No. And obstructive, what is an obstruction? It's blocked. Okay. And then pulmonary, we know lungs, and then it's a disease. There's no cure. It's going to permanently get worse and worse unless the patient does a few things. Notices that it's coming on, goes to the doctor, gets diagnosed. The doctor says, hey, stop smoking, stop doing this, stop doing that, do these things. And a lot of times, if the patient will listen and will do, if they catch it early enough, exactly what the doctor says, they can't reverse the COPD, but they can keep it from progressing. They can keep it from getting worse. But once you have COPD, you're always a little more susceptible to upper and lower respiratory tract infections. Okay. And like I said, there's no cure. All they can do is treat the signs and the symptoms. And then this is another picture. And like I said, these two guys kind of just, they go together. If you have COPD, you know, you're usually rocking the chronic bronchitis, you know, that coughing. They get up in the morning and they just hack, and then they cough throughout the day. And that's because of all that excess mucus. And then the emphysema eventually starts to occur because that's when the alveoli themselves start to break down. And that is decreasing the total amount of oxygen cells that they have to do that trading with. You know, bring in the CO2 and the uh, other things that the body needs to get rid of, and a place for an exchange of good O2 and for the hemoglobin for the red blood cells, right? And the less of the alveoli that there are, the less that's going to happen. So a lot of times you'll see these patients on oxygen because they've wrecked their alveoli. They've got chronic respiratory problems. And you notice here, he's got a few things working for him. And I like the picture because it really helps us visualize. So there's his oxygen because he's not been able to breathe like he should. Here's his tissues because he's coughing up lots of mucus and phlegm. But do you see what this is? His cigarette. Because are they going to give it up? No. I've seen patients pushing O2 and IVs and walking all the way down the, you know, a block so they could still have their cigarette while they're a patient in the hospital. Blows my mind. A lot of times you will see the patient is very orthopenic. What is that? That means they have to be in a certain position to aid their breathing. Remember? They tire easily. They use a lot of accessory muscles, intercostal muscles, and that leads over a long period of time them to develop what we call barrel chest. They have dyspnea. What was this? Difficulty breathing. They have a chronic cough, and a pursed lip is when you see somebody who's breathing like, and that's accessory. That's trying to assist the oxygen. And then a lot of times they'll become thin in appearance. Besides the large barrel-like chest, and then digital clubbing. And this doesn't mean going out, you know, dancing to rave music or something. This means that the digits become clubbed shaped. And I'll show you. But first, this is the barrel chest. So here's your normal chest, right? But over years of overexerting and using all of those excessive intercostal muscles, it actually makes them larger and more expanded. Is this a good thing? Like, oh, grandpa's buff. No, it just means that his COPD is pretty bad to where the point that, you know, he's constantly using those accessory muscles to assist his breathing. And this is the clubbing that I was talking about. A lot of times you'll see in the digits, especially the fingers of people with COPD, that the ends of their fingers begin to become squared or cubed or round shaped. And that is because of a lack of oxygenation to peripheral, to the ends of the fingertips, to the toes, and different things like that. Because the body's like, well, you know what? The fingertips just right now aren't my biggest concern. Keeping the heart and the lung and the liver and the brain oxygenated right now, since we have such little, it's going to be a little more important. So we see this effect. All right. And it can take on various forms. This is just one, and it's a pretty severe form. Oh, cor pulmonale also happens with COPD. And this is usually a late stage. And what ends up happening is that the heart, because of how hard the lungs and the respiratory system are working, the heart's working hard too. Because remember, they're a pair. Everything works together. So we start seeing the patient develop heart problems due to this. All right. Um, Expanded all the time. We talked about that. And then, like I said, it says 85 to 90% of all cases in the US are from cigarette smoking. And I would have to say, everybody that I ever picked up in my 17 years of 911 who had COPD was either still smoking or had been a lifelong smoker and recently quit or was trying to quit. I don't think I ever picked up a patient who had COPD who had never smoked. So that tells you something. And you see, like I said, your normal air, alveoli and the air sacs are nice. They're full. They're as they should be. Over time, they become empty. They become hollow. They become useless. And I probably don't have to tell you this because most of us already kind of know this. A healthy pair of lungs from somebody who's passed away versus a pair of lungs from somebody who passed away from lung cancer. Now, one of the most shocking things I ever saw was I sat on a few autopsies, and one of the doctors, he was a pathologist who had come in, and he was like, "Hey, come here," and he's like, "You got gloves on here," and he put my fingers across the lung, and when my fingers come back out, my gloves were covered with like this brownish, almost like a molasses type of, I don't know how to explain it. I was like, what is that? He said, tar. Those are lungs of a smoker. And I went, oh my God. And I was like, is that what killed the person? He's like, nah, that ain't what killed them. They ended up having a heart attack. And it was like, they're all kind of related, but yeah, those are smoker lungs. He said, this is what we see. And there's actually a tarry residue that stays on your lungs after years and years of smoking. So, and that's enough said right there to keep me. I never picked up a cigarette in my life. Acute, I'm checking my time. Acute bronchitis is different than the COPD chronic bronchitis, okay? Acute means sudden and rapid. Probably all of us have had a case of acute bronchitis. During the colder flu seasons, you go in, you have oh, my chest feels tight, and got a little wheezing, and maybe you're hacking, and so the doctor's like, hey, you got some bronchitis. Now, here's the issue. Bronchitis is usually caused by a virus, but because it's one of them things, do we bother getting a sputum sample, taking all this time, and it turning out that it is, and not putting them on antibiotics, and it turns out that it is a bacteria? No. So what doctors 90% of the time when a patient comes in exhibiting signs and symptoms of bronchitis is they're just going to put them on an antibiotic. That's one of the few times that it's a safer bet. And sure enough, every time I've had it, they didn't do the testing to, is it viral or is it, bacterial? They just here, take these antibiotics, here's some steroids, here's a nebulizer, and feel better. and always end up feeling better. Acute bronchitis can get pretty severe, because you can start producing that cough, causes the inflammation, and you get lots of mucus, and with either type, viral or bacterial. You can get fever from the infection, right? Chills, fatigue, shortness of breath, and difficulty when you breathe and pain, right? So acute bronchitis, even even though back in the old days it probably led to several deaths, nowadays it's very manageable, very treatable, and we don't usually have many complications in a healthy person. Somebody who had a pre-existing lung condition or somebody who had um, immunodeficiencies and stuff like that, they may have more trouble. One of the last things I'm going to cover for today is called cyanosis. Cyanosis is when you see a blue coloring on a patient. We see cyanosis because that means they are not getting the proper circulation and adequate oxygenation to those parts of the body that are blue. Common places to see cyanosis is the fingertips, the toes, like this baby here, the mouth, and the ear tips. All right? Those are usually some of the very first places that you'll see. And this is an emergency. This is something that immediately needs to be taken care of. Now, as a paramedic, I saw many cases where I would be called for baby difficulty breathing. And I'd get there and they had their noses they're little babies. Their noses were just caked in boogers. And one of the things, I'm not sure if a lot of y'all know, but most of your infants are nose breathers, right? And we have a massive portion of our airway completely blocked and full of, hardened mucus and so forth. Is that going to decrease your oxygen saturation? Absolutely. And so a lot of times I was the very bad guy because anytime it was a baby, the first thing I did is I pulled out my bulb syringe. And that's that thing, the one you get from the hospital, you'll never find one that's better. So you parents, if you have a baby, you beg them to give you a few of them, okay? And then you never, never, never lose it. Because the bulb syringe is going to be your best friend. Your child's going to hate you, but you will help you more than you know. You can try to find good ones but they're never the same as the ones the hospitals have. So with most of my cyanotic babies, I was able to look, and when they had visual signs, I would go in there and hold the baby down. They're like, and the moms and dads and whoever would be like, "Oh, they don't like that. That makes them mad." And me, I'm like, okay. I grab the kid, hold him down, and I just start. And what I did a lot of times is I would put out a chuck, or if we were outside, a lot of times they'd come running to me with the baby. I would just spray the mucus so they could see how much I was pulling out of their respiratory. And then I would do that. And I had always put the pulse oximeter on their fingers before, satin at 70, satin at 80, and continue to suction. And the baby's screaming and throwing a fit, and the mom's freaking out, and everybody's going crazy. But to me, when a baby's screaming, that means they're moving oxygen. That's a good thing. That's a paramedic thing. So when I'm sucking boogers, and then finally we get a nice clean nose, and I'm looking down and I show the mom the pulse oximeter that's either wrapped around the finger, wrapped around the toe, or whatever, and go, "Oh, look, we're sat at 99%. Isn't it amazing what happens when your child's airway's clear?" And they're like, "Well, but they don't like it." And I'm always like, "Be the parent, psh, psh. Suck their nose." And then you have to do that until your child is physically capable of blowing their nose properly. It is your job as a parent to suction their boogers. Parenting 101. That is one of my paramedic pet peeves. The other one is we'll talk about it, and that's when I see babies out of their car seats. If I was a cop, I wouldn't pull anybody over for almost nothing. Seeing your kid out of the car seat, I'd pull you over every time and I'd find every single thing I could find wrong with you. Broken tail light, muffler, this, everything. Because I've seen horrible things, kids not being in their seats. But cyanosis is where I'm going to end off. Now, are there other reasons for cyanosis? Absolutely. Febrile seizures, certain respiratory, heart conditions, things like that. Well, we'll pick up and we'll go from here tomorrow. I have my teledoc I got to get to, but does anybody have any questions real fast? No? Okay, well then what I'll do is once I'm out of my appointment, I will post a couple of videos for you. And on Microsoft. And then the other thing that I want to make sure everybody understands if you have labs on campus, you are not to go early. You cannot go to that lab until it is your scheduled time. Okay? You're in uniform. You have your lab coat. You have your stethoscope. You have your blood pressure kit. You have your mask. You have your hair pulled back. You are in all of the proper, MA required gear that you're supposed to be in, right? So make sure you know that. If you are on one of my online labs, these videos and how you respond to them, this is how you're getting your grade until we can get you back on campus for that hands-on, okay? So it's imperative that you're responding to these when I post them. And the other thing is your class is, and not, like I said, it's most of the time not anybody that's here. Your class is killing me with Survey Monkeys. Yesterday, I was having such a tough day. I just messaged everybody and said, look, your Survey Monkey ain't in. I ain't bothering you again. Do it or you're just not getting attendance. And I just don't, right now, because they have me doing tutoring and they have me teaching 2 classes, I do not have the time to chase everybody around. So if you're one of the ones who are my Survey Monkey issues and you're watching this later, get your Survey Monkeys in. If you know you got to be at work at 9 a.m., get up at 7 and do it. Turn it in. I got people, no lie. Justin's one of them. He sends me his Survey Monkey at the crack of dawn, as soon as it's the next day. And you know what? He never had a problem with his attendance. That's why, he's rocking the grades he's rocking, because he does exactly everything he needs to do on time, when it's scheduled, right off the bat, and I never have to ever ask for anything. And that's how that's what I need, okay? Y'all are all adults. So, but like I said, most of this doesn't apply to any of y'all, because y'all are some of my students. So, y'all have a good day. I'll post this after it uploads, after my meeting, and we'll see you tomorrow. Bye, guys.
You too, Miss Scaffa.
Make sure you hang up, okay?
Okay.
Bye-bye.